Welcome to the 100th edition of the Psychcast by MDedge, where we bring you the latest from leaders in the fields of psychiatry and psychology, including peer-to-peer conversations and masterclass lectures. I'm the voice of MDedge Podcasts, Nick Andrews. Coming up later, Editor-in-Chief of MDedge Psychiatry, Dr. Lorenzo Norris, welcomes Dr. Christine Adams. Dr. Adams and Dr. Norris discuss how emotional conditioning shapes lives and relationships, which is the subtitle of Dr. Adams' new book, Living on Automatic. Dr. Adams is a child, adolescent, and adult psychiatrist in Louisville, Kentucky. She's held academic positions at the University of Louisville. She's also contracted for the Department of Defense and with the Social Security Administration. She served as a forensic child psychiatrist for more than a quarter century. Their discussion about Dr. Adams' book is coming up later. But first, we're going to take a deeper dive into an important story from MDedge Psychiatry by Alicia Gallegos. The story is titled Breaking Through a Cloud of Silence. It was published online and on page 1 of the January 2020 edition of Clinical Psychiatry News. You can find a link to that story in the show notes. In the story, Alicia reported that the troubles that physicians have in seeking care for their own battles in mental health. Indeed, she reported that 400 physicians die by suicide each year. In this, our 100th episode of the Psychcast, we begin with a conversation on physician suicide and mental health care. I'm joined by Editor-in-Chief of MDedge Psychiatry, Dr. Lorenzo Norris, as he always accompanies us on this show. And Dr. Norris, let's just jump right in to the story. It was kind of jaw-dropping in a way. Everyone knows that there's some stigma around physician mental health and physician suicide, but just off the top, your initial thoughts on the reporting by Alicia Gallegos.
Well, it is jaw-dropping. It is rather concerning. My initial thoughts are that we're really, if you look at the literature, we really don't know the prevalence of physician suicide. What we can say, though, is that physician depression, physician substance use, physician anxiety, physician mental health, period, is still undertreated, and the vast majority of physicians are not getting really the treatment that they need to prevent this. So just off of the top of my head, these are the things that come to my mind. Extremely sad, unfortunate, and preventable, and it is just horrific that the nation's healthcare force, or essential part of the healthcare force, is dying unnecessarily. Yeah,
it's unbelievable, and the story begins, of course, with the anecdote about Dr. Matt Seaman, who completed suicide March of 2019. There is an obvious need for primary physicians to become better equipped to treat patients with mental illness, but Dr. Seaman was seeing a mental health counselor and a psychiatrist, but the care he got didn't meet those needs. How can psychiatrists and other mental health professionals become better equipped at treating patients who might have treatment-resistant depression or suicidal ideation? And what are the challenges with those patients being physicians?
Well, one of the things is how can psychiatrists as well as mental health professionals become better? One, you have to really, really, really build an alliance and take, if you will, a nuanced, detailed approach in terms of your suicide assessment as well as assessing the risk. The other thing is, if the treatment strategies are not working, you have to immediately elevate into something that is hopefully going to, if you will, address suicide quickly, whether that be ECT, whether that be some form of combination pharmacotherapy, whether that is intensive outpatient therapy. There are a number of things that one can do, whether it's the use of tricyclic antidepressants. Again, I don't want to sit here and play armchair mental health professional, but the idea being that, one, we build a relationship with our patients. We listen very closely to what they're saying and what they're not saying. And for me, it's being willing to escalate very quickly into other modalities that can quickly address depression, as well as keeping the patient linked in regards to escalating the level and intensity of the care that they're receiving.
Yeah, and the treatment-resistant depression, obviously a scary situation, especially for those who have knowledge of the healthcare system. It seems like a perfect cocktail for a disaster. But at one point in the story, Dr. Seaman, he was told to go to the ED where he had worked for so long for psychiatric care, and he recoiled at that. That's according to his wife in the story. Do you think that that's a problem, and can protocols be put in place so that if a physician, whether practicing or retired like Dr. Seaman, it needs to seek care, that they don't have to go to the place where they worked, or that they could be protected or maybe provided some anonymity? And how do you think that would work?
This is actually a very common problem in regards to, unfortunately, stigma in the mental health profession, or not stigma in the mental health profession, but rather stigma in regards to physicians seeking treatment. There are a couple of different ways that you can go about this. One, we can refer our colleagues to institutions in which they are not affiliated with. This is usually, for the most part, a standard protocol, if possible, and you can actually arrange with different institutions in your region that they will actually see your physicians without, very quickly. At times they will actually go in and they will have an alias or something of that nature. But the idea being is that at times we have to make sure that we have what is necessary so the physicians do not have to seek the mental health treatment at the place at which they're working or training or teaching. I can tell you right now that will be an immediate impediment. The other way to do it, other than actually having something set up where physicians actually go to a different institution, this is something that's, depending on what region you're in, it's very common in medical schools. The other thing that you can do is actually have dedicated mental health services for physicians in-house. From the start, just dedicated mental health services for the physicians in-house. So it is confidential. It is set up outside of the primary area where you would normally go to the ED or anything of that nature. It is specifically set up for physicians. At times, depending on the service, it can be essentially 24/7. Yes, it costs money, but it avoids obstacles, stigma, and it's there for physicians, as well as trainees, as well as all those folks in different levels of training. So I would say that there's really two main things. There certainly are more, but I'm focused on two main things. One, set up a relationship with institutions in your area in which the physicians can go and get, here's the key, immediate treatment. In other words, someone needs to be able to get on the phone, call a receiving clinician on the other end and said, I am sending Dr. X, Y, or Z, or medical student X, Y, or Z, or resident X, Y, or Z, and I need this person immediately seen and walked through triage where they're not sitting there and waiting. That's kind of going through the standard process but it's at the other institution. The other way is if you actually have in-house services, which again costs money, but you could immediately break down barriers. And what I mean by in-house services, I mean services dedicated strictly to nothing other than the mental health care of your physicians.
Sure. No, that makes total sense to me, and it seems like there's some real points in there where action can be taken in the immediate and I guess middle future, like next 6 months, 6 years. All of those things you said seem like they can be instituted pretty easily. Medscape that has a physician burnout and suicide report. That is a survey on physician burnout, and Medscape, of course, is owned and operated by the same parent company as MDedge and the Psychcast. And the statistic is 49% of all physicians report being that they would accept less work or accept less pay for less work. That includes millennials, Gen Xers, and baby boomers. Essentially, for anyone who was born from like 1942 after, with less money for less pay, which to me seems that there's an obvious solution out there. But what say you?
Okay, that is really a great question. All right, and interestingly enough, I was just actually talking about burnout to our medical students, and burnout, depending on how one conceptualizes the syndrome, but we're usually looking at emotional exhaustion, all right, depersonalization, cynicism, and low sense of personal accomplishment. I'm going to focus definitely for right now on emotional exhaustion. If we work less, if the physicians take less work, that's going to have an effect on burnout and maybe consequently development of depression and anxiety, which we're only now starting to tease out. I think for a subset of the population that is in that burnout syndrome, which I actually think is a heterogeneous syndrome, which is composed of those with clinical, if you will, diagnosable depression, unipolar depression, bipolar disorder, generalized anxiety disorder, as well as those that are dealing with, if you will, for lack of a better word, demoralization. All right, as well as those that are what we would say are classically burnt out in the original conceptualization of a caregiver going above and beyond and having simply no more gas in the tank. I think cutting back briefly or cutting back on the hours can be of benefit to perhaps the classically burnt out group, but only with the following caveats. only if they have an increased sense of control and autonomy in their lives and they're doing something that they find a sense of meaning and passion on with. If you just cut back, I do not believe that that in and of itself will do it. Because when I've spoken with clinicians, it's not actually the workload per se. The workload is a big thing, but that's why the duty hours adjustments did not really make that big of a dent on burnout. It's not so much the workload, it's whether the sense of control and whether a person finds a sense of passion and meaning in their life. This is what I'm looking at when I've worked with medical students, residents, as well as clinicians. So yes, cutting back certainly could be useful in terms of addressing burnout. Now, interestingly, cutting back on part-time, for physicians cutting back, you might say, okay, well, if they cut back, then we can hire more physicians. And then, that could also cut back on the overall workload. We can get more of a team-based approach. See, the problem with all of that is that we're facing, if you will, a healthcare shortage, period, whether it's physicians, nurses, PAs. So cutting back is not, unfortunately, is not, unless the person makes an effort to do that. I can't necessarily say an institution is going to have the resources to have a number of physicians work part-time because they just don't have enough. And I'm saying physicians, but I could also say NPs or physician assistants. They do not have we need more people in the workforce. Right. So cutting back, while useful for the person, would be very difficult for the institution because then we're going to have more people undertreated. So it really is a challenge. And I would also add that the pipeline that we have for producing physicians is just too slow right now. That's not going to be the answer. We're going to need different and novel solutions that integrate different aspects of all of us in the mental health profession. So great question. Great question.
Yeah, no, the shortage just seems to be like a real issue. If there were more physicians in circulation, then you could have more part-time people, but it's something that just, it seems like it's a never-ending Rubik's Cube of how to get everything on the same page at the same time. But final question about the story is it comes from our producer, Gina Henderson, who is integral in putting together the story and, of course, as a producer of the show. How would you feel about the specialty along the same lines as workload and fulfillment, psychiatry moving away from 15-minute checks and back to the days when you spent more time with a patient or patients?
That's an interesting question. That's a really interesting question. When I think about this, I really think about, this is really difficult. I think about, one, we've done that before, and I can't honestly say that we actually made a dent in suicide, and clearly suicide rates have gone up. I do feel as though if you could implement a triage model where where a 15-minute check would be indicated and when a longer interview would be indicated, I think that would be great. The problem is nobody can implement that model. We do not have any, if you will, at this point in time, people are like Dr. Gallagher and others are developing different types of criteria, things to look at in terms of suicide-specific crisis syndrome. But as it is right now, suicide is a low-frequency event. So even trying to, if you will, determine which patient would benefit from a longer interview, and then how can you actually, if you will, what is the intervention for that interview and the quality of training, that becomes rather difficult. In regards to, I'm actually going to go a little bit further, maybe a further afield than what people may be thinking, as opposed to psychiatrists increasing to 30-minute interviews, which ultimately would probably end up with less patients being seen. The quality maybe that those patients would get hopefully would improve perhaps, but with less patients being seen, I actually think this starts to get into more of how we look at our society and our social conditions. Mm-hmm. I'd rather have a stable economic, social network as opposed to necessarily strictly more mental health professionals doing longer interviews. Where am I going at? I'm going at probably more things that are in society that we know are influencing, if you will, mental health in general. In other words, I'm looking at prevention. Right. I'm trying to go, what do we put in the water, so to speak, to stop something? I am not convinced that more mental health professionals, whether it's nurse practitioners, PAs, psychiatrists, are going to stem the tide of this. I think it's the mindset of let's give this more attention with more, if you will, nuanced focus in regards to longer interviews, I think is great. However, I would not do that until I've actually seen an improvement in how we go about diagnosing and treating suicide, because I think you could just be leveraging more time and not getting the benefit. Now, what I would say, there are certainly obvious situations or very clear situations where a clinician should have the liberty to certainly spend half an hour or an hour with a patient. That is where I would absolutely would agree with Gina, in that if you are backed up 15 minutes, one right after another, and you have a patient that you want to go deeper with, and it's just very obvious, but you can't because you have another 15-minute appointment, that's something that I feel needs to be addressed.
Yeah,
all right.
Definitely.
If you do not have any ability in your schedule or anyone in your clinic that can back you up in regards to working with whether it's a student, a resident, or a physician, I mean, we could say this in terms of the general population, but if you do not have that in place, then actually that's a problem. That's where the problem with the 15 minutes comes in, because there are times that you have to go over. And given our current, depending on where you're at, going over can be exceedingly problematic, and then also affect your quality of life because you're not getting home until 8 or 10, particularly when you get to chart work. So I think there needs to be I would propose that clinicians need to have some ability or autonomy or buffer in their day to where they can go over.
Yeah.
That's probably how I would phrase it. In terms of it, instead of every appointment being 30 minutes, give me the flexibility to where if I need this patient to come back or if I need to reschedule somebody, I can do that.
Yeah, the ability to call an audible or just improv a little bit if you need to. Yeah.
Yes, that is what I would look for. And unfortunately, we know that roughly the vast majority of our patients, I'm segueing out of physicians here right now, they get most of their mental health in primary care,
sure,
which is absolutely, at 15 minutes is actually quite a long time in primary care. So it is, I like what you said, Nick, it's a Rubik's Cube. This is not an easy solution.
The story is jaw-dropping, and it's something that if you wanted to spend your entire career just reporting on suicide in different professions, you could do that. There's so much data coming out, and the rate is going up around the general population, and it's mimicked, of course, in healthcare. And so we wanted to thank Dr. Norris for coming along and shedding a little bit light and giving a little bit more detail to the story by Ms. Gallegos. And you can read the story in its entirety. It's in the January edition of MDedge Psychiatry, and it's also online at mdedge.com/psychiatry. There will be a link to it in the show notes. Well, Dr. Lorenzo Norris, I really appreciate you taking the time out of your day and giving us a little bit more to sink our teeth into here.
Okay. Well, thank you so very much for speaking with me, Nick.
Coming up later, Dr. Norris welcomes Dr. Adams. Welcome back to the Psychcast by MDedge. I am Nick Andrews. Remember that there are robust show notes available wherever podcast notes can be found in your particular listening application. As we mentioned before, Dr. Adams recently wrote a book titled Living on Automatic, which is all about emotional conditioning in our daily lives. Here now, please welcome Dr. Christine Adams and Dr. Lorenzo Norris for their telephone conversation.
This is Dr. Lorenzo Norris, Editor-in-Chief of MDedge Psychiatry. I'd like to welcome you to today's Psychcast, in which we are privileged to be joined by Dr. Adams. Dr. Adams has recently written a book titled Living on Automatic, How Emotional Conditioning Shapes Our Lives and Relationships. And Dr. Adams is going to share with us just the process and how she went about writing Living on Automatic, and also share with us just her experience in over 40 years of actually working with and treating many, many, many people in terms of her own practice, as well as being a faculty member. So, Dr. Adams, please, welcome to the Psychcast.
Thank you so much.
Okay. So, Dr. Adams, had an opportunity to look at a little bit of Living on Automatic, and I was wondering if you could tell us, because you have a wealth of experience. I mean, just off of your introduction, 40 years of practice in the field of psychiatry, community and public health, as well as forensic psychiatry experience across the gamut of the lifespan. So clearly you have the ability to take a developmental perspective when it comes to the mental health condition, and how we can really work and collaborate with our patients. As I was reading Living on Automatic, I was struck by, in terms of some of the initial parts that you talked about, in terms of really your emphasis on trying to find, if you will, a way to think in a way that actually really benefits our patients and helps them, and the limits at times of what the theories have been in the past. So I was wondering if you could give us a bit of a backstory to writing Living on Automatic.
Sure, I'd be glad to. This book was started by my mentor, Homer B. Martin, who is was an adult psychiatrist, and he was. I met him when I was a psychiatry resident in training, and he became my mentor, and we worked together over about 30 years before he died. So he started writing the book, and he wrote on it for 22 years, and he just sort of took a clean slate to looking at how people were and how they functioned. He had a dynamic psychotherapy practice for 40 years, and during that time he amassed some new observations that are in the book. And when I became his supervisee as a resident, he started asking me questions about what do you see in children and how young do you see things that indicate what these kids are going to be like as they grow up. And so it started me thinking, and it increased my powers of observation of kids. And he wrote on the book for 22 years, and then he died, and the book was unfinished. And his wife asked me if I would finish the book, and I said, certainly, it would be an honor and a great tribute to this man who really thought outside the box and looked at things with fresh eyes. And so it took me 8 years to finish it. I didn't know it was going to take so long, but we wanted it accessible to trainees and also to the general public, to help them understand relationships better and personalities better. Okay. And it was published in August of 2018, so it's been out a little over a year now.
Okay. All right, so Dr. Adams, thank you for a bit of that back history. Can you tell our listeners and our audience a bit of what Living on Automatic is about, and what the premise is and what it is that you're trying to accomplish?
Sure. It's the idea that we live on autopilot. We have knee-jerk reactions in our closest relationships where we just react emotionally without thinking about what's necessary, what's called for each person, and in what amounts. And so it's a living on autopilot. And what Dr. Martin discovered is that people are emotionally conditioned. You remember in school we learned about Pavlovian conditioning, and how Pavlov observed that his dogs, which had a cannula in their salivary glands, produced saliva, and he measured the amount of saliva when they ate food, and he discovered that they became conditioned to the handlers that came in the room. Even though the handlers brought no food, they still produced saliva. So that's a type of learning that's a conditioned response. Well, what Dr. Martin discovered and what I contributed to was the idea that people are emotionally conditioned in the first few years of life. Children learn emotional relationship patterns from the family or the adults that they grow up with, and that these emotional patterns are conditioned, and therefore they become like automatic knee-jerk reactions to people. Thinking is not involved. If Pavlov's dogs had thought about their salivary glands producing saliva just when the handler walked in the room, even though he wasn't bringing any food, they would have said, well, this is ridiculous. I'm not going to produce saliva for this. There's no food. But we have these automatic reactions to people, and at times we catch ourselves. We say, oh my gosh, I got so angry at my spouse the other day, I'm not going to do that again. And then you find that it happens again, and you can't control it, and it just happens automatically. Or I'm not going to yell at my kids anymore, and then you find the next day you're yelling at your kids again, and you go, gosh, I didn't want to do that. So those are the sorts of automatic patterns that we wrote about in the book, and we talk about how they are transmitted from parents to children, and then we talk about sort of through the lifespan how they get reinforced with children as they grow up outside the family and at school, and then as the children form dating relationships and romantic relationships, they continue to be reinforced, and then you have things primed for the next generation to be emotionally conditioned in the same patterns. So we followed it all the way through the lifespan. I saw children, adolescents, and adults, and Dr. Martin just saw adults. So we worked with thousands of people in long-term dynamic psychotherapy, from parents that had infants with problems all the way up to people in their 90s. So we did 80 years combined effort in this book, working with thousands of people for anywhere from 2 to 10, 15 years in psychotherapy.
Well, very interesting in regards to, again, this idea of the emotional conditioning. Now, what I do think about it, because you all are coming from, if you will, a psychodynamic wheelhouse, so to speak, this idea of emotional conditioning or patterns repeating themselves and things occurring in the, if you will, developmentally as our early on in the family of origin, what we learn, what we repeat. Many of these things resonate with me in terms of, if you will, I'd say, psychodynamic or psychoanalytic training that we might get. What would you say is a little bit different from the in regards to the approach that you and Dr. Martin have taken in terms of looking at this?
Well, we look at it when he discovered that this was mainly a conditioned thing that people were learning, and it was outside their awareness, and it was outside their parents' awareness. He helped patients, and I did too, in psychotherapy, uncover, first of all, what were the patterns that you learned in the psychotherapy. How did people relate to you? What were your memories about your mother, your father, your aunts, uncles, siblings? So that was the first part. Then the second part, once the patterns were uncovered and sort of made move from the emotional realm to the intellectual realm, then it was, okay, you're free now to interrupt the patterns, and it was the beginning to help people interrupt the patterns that were dysfunctional and that weren't serving them well in relationships. And so it's like taking blinders off a horse. If you have the blinders on, you're only seeing a part of the world, your world. And if you take the blinders off, you're able to see a much broader perspective on your own personal universe. And so you can make different selections, you can have different outcomes, you cannot decide you don't want to be attracted to people that you were attracted to before, and you have an understanding of why you were attracted to people that may have been unsavory for you. So you're free to make changes, and then that's the second part of therapy, is helping people make the changes that they want to make.
Okay. All right. When Dr. Adams, when you speak about this is what I think about. I think about maybe your typical clinician right now engaged in some form of psychotherapy coming out of training, and one of the things that gets thrown around is, for lack of a better word, an eclectic approach where we take different components of different schools and blend them together. When I think about what you all are doing in the book, or what I'm hearing right now, I feel as though you're really taking, you may correct me if I'm wrong, it feels like you're taking a new look and maybe taking the best of two approaches, maybe from CBT as well as psychodynamics. With psychodynamics, like, if you will, uncovering the blinds, making somebody aware of actually what these patterns are, which can be a great deal of work. But maybe in the past, where psychodynamics or psychoanalytic therapy hasn't necessarily gone the next step, is with the actual interventions or the behavior or the modifications. But what I would actually say, as being someone who was trained in CBT and DBT, is that even when you train in the skills and the modifications, if you don't actually go back and get to the awareness or the unconscious or the patterns, that falls short. So when I think of it, I think that you're putting a new lens on, or a different lens on, something that I think a number of clinicians over years naturally come to, but they may not be able to always articulate it. How do you take both of these schools or approaches and blend it in a way that is of utility for the patient and realize that you actually need both? So that's when you talk, and I think about living on automatic, that's kind of what comes to mind. So I just put that out there.
Okay. Yeah, I see where you're coming from. I understand. I think that it goes a bit deeper than the CBT, and it doesn't go quite the way psychoanalytic. Psychoanalytic gets into sort of the individual defenses and the intrapsychic structure. This is more relationship-based. We do go into, feelings and responses that a person has, but we don't get too much into the intrapsychic part. We do get into what are you thinking and feeling when your spouse comes home at 5 o'clock and you're getting anxious, things like that. Okay. And then the CBT part, I think that what we focus on is the antidote to automatic ways of reacting is thinking. So we get the person to start observing what they're doing in a relationship and also what the other person is doing. And these things are brought to therapy, and we dissect them. And this helps them increase their powers of observation, and then it helps them say, aha, what else can I do? How can I introduce thinking to slow the process down so that I don't react automatically? And then what is my best estimate of who needs what in this relationship, at what time, from which person, and how much? And all of that interrupts the automatic response, because we learn to respond one way to mom or one way to dad, and then we marry somebody and we take one of those ways of responding into the marriage, so that we react according to the person and not the situation that's called for.
Okay. That makes a lot of sense. One thing is, I was thinking about it because I was using CBT in kind of a broad frame, but you really focused on the relationships, what you all are doing, and living in automatic. How is that? What are the differences from that compared to interpersonal psychotherapy?
Well, we didn't set out to demarcate differences or similarities with other things. He just started out with observing and seeing what worked with patients. So I realized there are aspects of all these things that have gone before. The interpersonal focus is that relationships cause emotional distress. And so if you can correct the dynamics or the way the relationship is conducted, at least from your end, you cause a ripple effect in the other person, in the children in the family. So this is the interpersonal aspect of it, that you change one cog in the wheel and you're going to change the way other people respond. If say a wife is used to doing everything that a husband wants, even though she has a full-time job, and he comes home and he starts demanding, I want this for dinner, and she jumps up and tries to accommodate that want. If that's her MO with her husband in all interactions, then that's something that's going to eventually make her emotionally ill. She's going to suffer with depression or anxiety or overload, substance abuse, a whole host of things. So if you can help her understand how she learned to react this way, where that came from in her childhood, what was the pattern that she learned that dictated this response, then she can grapple with how reasonable is that to do everything he wants at 5 o'clock and make a whole new dinner just because he asks for it or demands it. And then she's free to say, well, I don't think that's reasonable maybe 3 days a week, but maybe it is 4. Or I don't think that's reasonable, period. I'll do it 1 day a week. and then she learns how to communicate that to him, and he either has to make a change or he has to leave the relationship.
Okay.
So it helps people, since relationships are so key in creating emotional problems in people and substance abuse, it helps them get better, and it helps them make changes in their core personality that was set up when they learned this conditioning early in life.
Okay. Well, Doctor, thank you for just detailing that. Again, when I hear you speak about it, I'm hearing, again, a focus on relationships. I'd also say a focus on what works in terms of helping our patients and collaborating with them. So a focus on relationships, a focus on what works. And something else that you all did, which I wanted you to comment on in terms of the choice and how you wrote the book. You mentioned before that you were very intentional, well, maybe I just put that word in there, intentional, about making the book accessible to patients as well as those in training. Can you tell us a bit about that? Because I can tell I think from how you're talking, which I agree with, you're trying to focus on what works, what works, and how can we actually give people accessible language that they can use to change their lives.
Yes, absolutely. Dr. Martin wanted the book to be for general readers, but he happened to have a writing style that was very lofty. And so I worked with a couple of editors, and we got the language down to 11th to 12th grade level.
Okay.
Because the idea was, can you teach people that are not in psychotherapy some of the things that you helped patients in psychotherapy learn, and will they benefit from it? So in order to test this, before I got the book out, I started teaching classes at a local university on the concepts in the book. And people were very enthused. They remembered things. People have come up to me even 3 years after I taught classes and said, that really improved my relationship with my grandkids, and I'll tell you why. So it stuck with people. They could digest it, they could understand it, and they could put it to use. And that's what he and I wanted, because there are many, many people that cannot access good psychotherapy that they need for financial reasons, or they just can't find people in their community. And so we wanted to see if these concepts that we'd worked on for 80 years with thousands of people could help even more people.
Okay.
So,
now that's...
and also trainees, people that are just learning how to be psychiatrists and how to do psychotherapy.
Okay. Now that's very, very interesting to me, because just in terms of my role, at times I'm in the hospital, in terms I'm in a medical school, at times I'm with residents, and you mentioned this again in the book, this emphasis on what works and what's accessible, and I definitely think that what works in the classroom should work on the streets with the patients. And I'm curious in regards to some of those concepts you were sharing in the classes or the lectures or things that you were with the general public. What ideas seem to resonate the most or stick, as you put it? What seemed to stick with people that they really grasped onto?
Well, I took them through the same process that I take residents that I supervise through. We use mainstream movies in the classroom.
Okay.
So that, and I pick movies where people are in different personality groups or roles, conditioned roles, and they're interacting a lot, so that you get to see the different types of roles and how people carry on. And what I wanted people to do was, first of all, learn to observe and keep yourself out of it, so in order to avoid projecting. So somebody would say in the class, well, that person's obviously very angry and they're telling them off and blah, blah, blah. And I would say, no, wait a minute. I just want you to tell me what you're observing, not what you're putting into it. So the first thing was teaching them to observe. The second thing was teaching them the different emotionally conditioned roles that we found in people. And then the third thing was helping them to understand if one of the people in the movies was to change the role a little bit and not do something that they were doing, tweak it a little bit, how would that affect the other person? And this is where they brought their own life experience to the class and discussed personal things that they had experienced in relationships when they tried to make a change or whatever. This is a 6-week class for an hour and a half. And so we went through observing, knowing what the roles are, thinking about how to interrupt the automatic response, and then their observations about how it would work in their personal life. So sort of 4 steps.
All right. Very, very interesting. I wanted to go back to, I don't want to give away the entire book, so to speak, but could you maybe give us an idea of one of the emotionally conditioned roles that when folks are looking at the movie, which I actually think I want to go back to actually using movie or media as a way in which to talk about these emotionally conditioned roles, but maybe one of the roles that you all have highlighted or that you discovered, the emotionally conditioned roles?
Sure. They actually go together. You know, we had to understand how is it that people around the globe, you know, a man from Indonesia who moves to the United States and meets a woman in the United States, how is it that they can have a relationship that is the same as a couple in the United States who are both from the United States? You know, how does that work? So there's ways that people fit together, and the ways we discovered in relating have to do with giving emotional support and taking emotional support.
Okay.
So one role is people that are very good at supporting especially needy people. They do things for them, they inquire how they are, they bend over backwards to accommodate them. The other type of person is the person who's very good at accepting emotional support and even demanding it. They want what they want when they want it. They are very needy acting. They can't follow through with promises that they make to do things. They may have trouble getting to their job on time, you know, getting their laundry done. So these are people that are extraordinarily good at taking emotional support in relationships. So in a nutshell, those are the 2 types that we found that often go together in marriages or in friendships, and siblings in the same family. One will be conditioned one way. The next one will likely be conditioned the opposite way. And then the third child can either be a replica of the first type of conditioning or the second child's conditioning. So it sort of alternates in families, but doesn't have to alternate. But there are some of each type of children raised by the same parents in each family.
Okay.
Another thing that we found.
Okay. Now, Dr. Adams, you mentioned some, like you would use movies or media. Can you tell us maybe 1 or 2 of the movies that you found useful in terms of illustrating some of these, if you will, emotionally conditioned roles?
Well, sure. Let's see. I've got a whole shelf full. One of them was a very old movie called Ordinary People. Another one was a movie called Gran Torino with Clint Eastwood.
Oh, okay.
Played a sort of snarly old curmudgeon. And another one was Remains of the Day with Anthony Hopkins and Emma Thompson. And The Door in the Floor is one. I also used HUD, a very old movie with Paul Newman. When Harry Met Sally.
Oh, okay. Wait, Kim. Okay, I was waiting for you to say one that I didn't want to go to Remains of the Day. I was waiting for you to say one that I like rewatch all the time. When Harry Met Sally.
Right.
Okay. Yeah. How can you break that down for us? Yeah.
Yeah, those are the main movies that I've used in the classes. Okay.
What about with Harry Met Sally? How would you approach that with in a class in terms of understanding emotionally conditioned roles?
Well, just those 4 steps that I mentioned. First, learning to observe, teach people how to observe interactions between people without projecting themselves into it. And in that movie, you'll recall that the girl, she and he, were very vituperative with one another when they were in college. They sort of engaged in a lot of nitpicking with one another. They were disgruntled, and irritated by one another. And then as they went through a series of relationships, each one, they, in essence, mellowed a little bit, and they realized that there were things about one another that they really liked. And they both had a similar type of personality, and that's why they were at one another's throats as young people. But with life experience in dating some people that weren't very good for them, each of them had that opportunity, they began to see what a lot of people see after a second or third marriage. You know, there's some different kinds of people out there in the world than the one I've been attracted to. So let me take a better look at this person that I'm sort of automatically rejecting all the time, and let me see if they really have any endearing qualities. And that's what happens in When Harry Met Sally.
Okay.
And that's what I help the people in the class to observe and to understand, that two similar role people, two similar conditioned people can have a lot of friction at first, whereas two oppositely conditioned people fall madly in love, and it doesn't work out because of the roles that they were raised in are so different that they can't really be very good at compromise or working things out with one another.
That is, I'll never look at When Harry Met Sally again the same way. So that is, but absolutely one, certainly a movie that I do actually appreciate, and I was speaking with one of my colleagues in regards to movies of that ilk recently. But I like what you're getting at in terms of the conditioning, as well as the idea that it's in certain ways it might be counterintuitive, and that idea in terms that what you just said in terms of looking at a closer look at folks that we were already auto-rejecting, and that idea of going through life and having some relationship experiences as a way of learning about like our own emotional conditioning as well as that of others. And I went back to the movies because I going back to a little bit of an idea of like what can we utilize with patients or what can we do on the ground. I mean, I can't speak for others, but you know, I like movies. I like to watch movies. I like to talk about movies. Actually, quite a bit, and I do definitely think about bringing out movies as a way in which to kind of engage in it's almost like a rather organic discussion that you could entertain. You could pull this out at any point in time. I mean, I could actually go out to my office and start talking about this right now, and it speaks to that idea where I think you all are trying to go with being accessible and using what's out there in a direct language that can give people tools to help them really just manage their relationships.
Yeah,
so
it doesn't
on that
help
note,
to talk to people in ethereal terms.
No, it does
They
not.
have to have something concrete, either their own relationships to look at, or to learn something by starting with a movie and then having lots of people in the class plus the instructor sort of guide you in how to observe and what your observations mean. Is very enriching to people because it's concrete. It's like daily life.
Yeah, absolutely. I agree completely. Absolutely. And I wanted to follow up in regards to that idea of relationships and relationship management, and it's also this idea of auto-rejecting or rejecting folks, and we're taking a closer look on that. Can you tell us a little bit more about, or just your own thoughts about, how can we begin to decrease our automatic ways of managing relationships? Like really digging into that idea of don't just do things automatically in terms of how you manage your relationships, but think a little bit more about it. I know you've already given us the 4-step process, if you will, but if there's other insights that you can give us, Dr. Adams.
No, I think the hardest thing is to get people focused on making observations. You know, people are so used to reacting automatically that they don't stop and say, wait a minute, what are you talking about? What are you asking me to do? What's going on here between us? So the observing is really a hard first step, but it slows people down when you observe and you start thinking. Then you're movie of your life becomes in slow motion. And when it comes in slow motion, you see a lot more that's going on. So I don't have really much more to add other than the antidote to emotional conditioning is thinking and observing.
Well, I would absolutely agree with you. I mean, a couple of things that really come to mind. Two of my colleagues that I've talked with before, my colleague Dr. Kinkin, who we both work in trained residents. One of the things we always talk about or we think about is that idea of observing and getting people to actually look at a thing, like actually slow down and observe. And that it's interesting how that applies to training as well as, if you will, just life in general in terms of your relationships. But I agree with you. One of the most difficult things to do is the observation. And then another thing is, another person is one of my, a colleague of mine, Miss Whitney Fishburne. She and I were recently talking about this idea of thinking, and you combine both of them, like observing and thinking. And this idea, like, not only do you have to observe, you have to think. And I would also say that, going back to what you have to do it in a way that's accessible, that's meaningful to you in your life, and in a language that makes sense. One of my issues with, I won't say issues, but I think challenges in terms of academics, because that's part of where I live, is that we can get to, you had mentioned this before in regards to the initial writing of the book, that if we're too lofty, if we're using language that people cannot access, including ourselves, then it just ultimately, it's not sustainable, it's not reliable, and it doesn't work. So I'm a big fan of anything that's accessible, reliable, and that works, and that's why I was originally, still am, a huge fan of DBT, because many of its components, I think you can just break that out anywhere. So, but when you're talking about living on automatic, this sounds like a language or a way of viewing things that is going to potentially keep the focus on people in terms of their relationships, as well as their connectedness to each other and why they're connected to each other, and give them a lens in which to talk about this that's accessible. So, that's good.
It also takes away a lot of the stigma and embarrassment with having an anxiety or depression from a conflict in a relationship, because people realize, oh my gosh, that just happened to me. I learned that without even knowing what I was learning as a child. And my parents didn't know what they were doing. And it's remediable. You can work it out in psychotherapy, as some people can work it out after reading a book like ours. And so many people have told me when I give lectures, I didn't know the personality could be changed. I didn't know you could make any changes in yourself once you were set in childhood. And I said, absolutely, that's what we've done for 80 years, and it's very possible. It's very effective, very effective.
Okay. All right. So, Dr. Adams, I want to thank you so very much for sharing your insights with all of your experience living on automatic. Really, you've given us a different and a new perspective in terms of looking at relationships, all right, and how we can work with our patients and recognize these emotionally conditioned roles. I personally really like the way in which you utilize movies or that person's story to look at it, and I'm hoping maybe at some point in time we can have you back on the Psychcast, and I don't know, we can break down Gone with the Wind or some other stuff like that. Or one of my other favorite movies is, I don't know how you break down Lord of the Rings, but I mean, but if anyone could do it, I mean, maybe that should be a challenge. We need to break. Oh, what about Star Wars? I mean, that would actually be there. That's kind of emotionally conditioned roles or something of that nature. So, sorry, audience, I had to go there. So, but in any event, listen, thank you so very much for joining us, and hopefully we can have you back again.
Thank you so much.
And that concludes the 100th episode of the Psychcast by MDedge. The Psychcast is produced by Gina Henderson and Jeff Bauer. All of our podcasts are produced by MDedge editors Ivan Oransky, Kathy Skarbeck, and Mary Ellen Schneider, as well as multimedia editor Terry Rudd and multimedia producer Tyler Mundak. Social media is produced by Kyla Clark. I am your audio engineer, audio editor, producer, and the voice of MDedge podcasts, Nick Andrews. You've been listening to the Psychcast by MDedge.